Thanks, Tom. I'm absolutely delighted to be here at this terrific venue for a meeting. I want to begin with just a brief announcement for anybody who happens to find themselves on the tee with Walt Beaver today or tomorrow. If you visit the North Carolina State Golf Association website, you'll see that his index is actually 3 rather than the 12.3 that he'll recount to you on the tee. I'm sure it's an honest mistake, Walt. I'm not holding a grudge. Bring cash, that's right. Yeah, your cash will work. So anyway, I'm going to talk about cup position, particularly its implications regarding stability and impingement. And the things that I want to accomplish are two. I want to identify the optimum cup position that I shoot for, and I want to tell you about the things that I've learned over the last 20 years to recognize before the operation and during it to help me get to that optimum position. You know, we worry a lot about instabilities, but the issues of the importance of cup position are really even more day-to-day for patients than we frequently recognize. It's important for us to realize that total hip patients aren't normal. Even though it's the greatest operation we got going, they don't have the same function as someone who didn't have a total hip regardless of how well we did the operation. And how we place the components, particularly the cup, has a big impact on how those patients function. This is from a study that we did at the University of Georgia several years ago. We published it 5 years ago, in fact. And what we found is if you look at just medialization of the cup and the impact of cup medialization on a patient's strength, controlling for age and sex and the size of the patient, we can ascribe 18% of the differences in those patients' abductor strength to the lack of cup medialization. So it's a big deal. When I'm doing a total hip, one of the first things I want to do is medialize the cup because I want to give my patient the best mechanical advantage that I can, and so I'm shooting for the bottom of the fovea. I expose it during the operation, take the soft tissue out of it so I can clearly see where it is, and I ream straight down. The other important thing for me is I want to avoid raising the center of rotation. That's why I start reaming straight down. Once I hit the floor, then I just put larger reamers in a stepwise fashion and expand until I've got good rim contact. I don't ream cephalad if I can avoid it at all. And that's because the height of the hip center is a very important factor, too, in terms of patient function. You know, most arthritic hip centers are high anyway, so you really actually want to try to lower them a little bit most of the time. And I showed you that how important body weight lever arm was. Look how important hip center is. You raise somebody's hip center and you can compromise their abductor strength dramatically. So now, once we figure out where we want the cup position in terms of its translations, how about alignment? Alignment is a big factor for us. It's something we really think about more than anything else. The whole last session was largely devoted to cup abduction and anteversion issues. What alignment do we really need? You know, and it's kind of interesting when you think about it. If you look at all our hip scoring instruments, range of motion in total hips is almost negated. It's only 5% of a hip society score. How much motion do we really need to have a highly functional hip? This is a nice article from, I think this is Davis and Merrill Ritter, I believe, wrote this article and identified patients in a high functional category. And as you can see, those patients had more than 115 degrees of flexion, abduction of 25 degrees, and very little flexion contracture. So those are the kind of ranges we want to try to achieve on the operating table when we look at the components, move the hip around, and try to be sure that there is no impingement. In terms of hitting those numbers, this is the range we want to be in to end up with a stable construct. We get out of this range 40 to 45 degrees of abduction plus or minus 10, 15 to 20 degrees of acetabular anteversion plus or minus 10. We've got a high risk of those hips becoming unstable. The things that I look for to try to achieve those positions begin before the operation. When I template patients preoperatively, I'm not really looking that closely at the size of the component as I am the position that I want to put it in and what I expect to see intraoperatively to know that I'm hitting those spots. Abduction, for instance, a big deal, especially with hard-on-hard bearings, as we've heard this morning. So I'm going to position this template on the x-ray, and I'm going to look not only for the fit that I get. As I said, that really isn't so critical to me. I'm going to look down here at the inferior cotyledons to see how prominent I expect them to be. I marked them on this x-ray, so you kind of can't really see that they're there because I used a pencil to make them more obvious. But if I see them on the x-ray and I abduct the cup to the proper position and I've bottomed it out in the fovea the way I meant to do it, things that I can see during the procedure, if I don't see these down here, then I don't have that cup in the position that I want it to be in. If they're not there in the operating room, something's wrong. They didn't go away. Now, some people use combined anteversion. Chit Ranawat's been talking about that for a long time, in which you kind of line up the head with the socket once you get it in there and look at the position of the leg and look for 45. That really doesn't work as well for me, simply because I can't rely on the position of the pelvis intraoperatively. I've used a lot of different hip positioners, and it turns out that in Georgia, where I operate, most of our patients don't get strapped in that tight because they've got a lot of extra tissue on board, and there's no telling where their pelvis goes. So I need a hard sign to localize the pelvis to help guide me to anteversion. This is a really nice article that I would recommend to all of you to look at. It's got a lot of pictures in it, and being from Georgia, I like articles with a lot of pictures. There's several interesting things about the paper, though. First of all, as we all probably have recognized by now, there's a tremendous variation in patient anteversion from specimen to specimen. There's a tremendous difference in acetabular anteversion by sex. So one range really doesn't fit anybody. When we look at what we can tell about the pelvis intraoperatively, it's hard to pick out reliable landmarks. Certainly the anterior rim, which a lot of people use, is highly variable and is not a good landmark. The transverse acetabular ligament has been used by a lot of people, but for me, I don't want to have to spend time removing osteophytes to identify it clearly before I ever start reaming. So it's not a cost-effective methodology, if you will. The sciatic notch, however, is a great landmark. If you draw a line from the sciatic notch to the posterior rim of the acetabulum, that line is parallel to the normal opening angle of almost every acetabulum you're ever going to come across. And I use that intraoperatively. Here's the view I'm going to get. This is 12 o'clock right up here. I put a hemostat into the sciatic notch. Imagine this line, move parallel to it, and I'm going to hit a neutral acetabular opening angle in that patient if I do that. If I want 15 degrees of anteversion, I just use the same landmark and shoot right across the center of the cup, and that's going to give me 15 degrees of anteversion if I'm doing a posterior approach, for instance. And that guides me to a pretty consistent version angle when I insert the cup. So I just imagine it just like that every time. And again, if I'm doing a posterior approach, I'll shoot this line for my reamer. And as you can see, I'm able to get a pretty reproducible alignment when I use those landmarks. The one thing you have to watch out for if you're putting a cup in neutral is avoiding overhang anteriorly, especially with modern hard-on-hard bearings. Cup edges are a little sharper than they used to be, and it's easy to get iliopsoas tendon impingement. So you always have to be sure after you've seated the cup initially that you can feel a little bone edge across the front. So in conclusion, don't forget to medialize the socket. These are the angles we're shooting for. Remember those intraoperative landmarks, and you'll end up with a good, stable construct with early recovery of your patient and great biomechanical function. Thank you very much.